tibial. So I'm going to work according to the clinical presentation. I'm going to work with the three articulations. I'm going to start with the patella. In patella, we have the normal four directions we already know, which are the medial, the lateral, the superior and inferior glides. What we are going to add? We are going to add a rotational glide. Rotational glide, I'm going to use both my whip spaces, and then I'm going to press down, then I'm going to rotate either to the left or to the right. Okay? Are we all okay? Second one is going to be called the patellar chilling. And patellar chilling is a very common technique to be used with the patellofemoral pain syndrome. So what I'm going to do, I'm going to use this snuff box to fix one side of the patella, and the other hand, I'm going to push the patella up. And I can do it on the other side. Fix one side like this, and then push patella up. Again, I'm going to fix one side, and the other side, I'm going to push the patella up. Okay?
Yes.
Any questions for patellar mobility?
What are the indications for it?
Patellofemoral pain syndromes. Okay?
And the rotations?
Rotation,
They
web
are also-
spaces. Yes, they are also for patellofemoral pain syndromes, and sometimes we use it post-operative because we need a very good patellar mobility in the first phases, especially for the ACL, meniscus repair. If you don't have a good patellar mobility, you are causing a disturbance in the ranges of flexion and extension within the rehabilitation.
Okay.
Okay, so patellar mobility, they are really recommended in phase 1 in post-operative knee surgeries. Okay?
It also leads to ON when it is prolonged osteoporosis.
According to what might make the patient comfortable.
Maybe repeat the rotation.
Rotational, use your web spaces on the superior and inferior surfaces. Press down, then rotate. Press down, then rotate.
Both sides.
Both sides together. Okay?
Now,
Then, yes. Okay. Okay. So now I'm gonna do femorotibial or tibiofemoral mobilization. So I have either anteroposterior or posterior, or I can use medial or lateral glides. Okay? Also, I have the rotational tibial mobilization. Okay?
yes.
If I need to do it anteroposterior, so I'm gonna just put my hands like this. With your palm, you are gonna just do A, B mobilization like this. Okay? If you wanna make it the opposite, remember the anterior drawer position. So you are gonna sit on the foot for more stabilization, and then push the muscle, then take the joint into posterior anterior direction. Or I can use the medial and the lateral direction. So if I supported the thigh from here, then this is which direction? It's lateral glide. So I'm gonna apply lateral glide, and even I can engage this with movement. If I started to stabilize this thigh from medial, this means that the direction of the glide will be
Internal.
lateral glide. This is medial glide.
Medial.
Okay? Remember when we said that we have inhibition in the glutes, we have two responses from the femur versus the tibia. So the femur tends to go into internal rotation, and the tibia tends to go into external rotation. So one of my treatment options as a symptom modification technique, I'm gonna apply internal rotation or medial rotation to the tibia with the flexion. So what I'm gonna do, I'm gonna hug the whole lower leg like this until I hook with the tibia. Close your hands with the shaft, and the other hand will fix the fibula. Do the internal rotation, then ask the patient to slide his leg on the bed. Remember that the patient should always slide the leg, otherwise it's going to be hip flexion rather than a knee flexion. Okay? Okay, again, I'm gonna just hug the leg like this, stabilize the tibial shaft, then hold the fibula, then go with medial rotation, then the patient's gonna slide the leg. Okay? Or I can use the prone direction. So I need you to lie prone. And from the prone position,